It is officially Lymphedema Awareness Month. My name is Kelly Thomas. I am a breast cancer survivor, and today I am joined by my breast reconstruction surgeon, Dr. Ashinoff, to answer a few questions you have on lymphedema. Dr. Ashinoff, what is lymphedema and what are some of its symptoms?
So lymphedema is an abnormal accumulation of fluid in a limb. It happens after breast cancer treatment. It can happen because of the cancer itself, or it can happen in relation to the radiation or the lymph node removal. There are other instances when it can happen without any of those things, but today we're going to focus more on the breast cancer-related lymphedema. And the symptoms can range from a mild swelling to a very dramatic increase in the limb size based on the severity and how long the patient has had it for.
Why are breast cancer patients at risk for developing lymphedema?
Well, because many of them have radiation to the lymph nodes, or they have lymph nodes removed, or both, and the lymph nodes are involved in the transport of the fluid from the limb, and when those are removed, both the scar tissue and the absence of the nodes can cause the limb to swell up.
Is there anything that can be done to prevent lymphedema?
So right now, there's nothing that can definitively be done to prevent it. There are some studies that have looked at surgical procedures to reconnect some of the lymphatics at the time of the lymph node removal, but it's not yet standard of care, although it may be soon. But other than that, there's nothing really that anyone can do to prevent it.
If a patient knows they will have surgery with lymph node removal, what steps should be taken pre and post surgery to limit and manage lymphedema risk?
So there's no way to limit it other than to remove as few lymph nodes as possible. But we like to send them to the therapist post-operatively, and before surgery we can measure the arm in a number of different ways. Both we can check the circumference, we can check the electrical impedance in the arm, we can measure the volume in different ways. Then we can measure it again after surgery to see if it's changed, and you can follow that throughout the patient's life. If they had any hint of a limb swelling, we'll send them to a therapist, and the therapist can evaluate them in terms of their limb volume. They can also begin massage and compression wrapping, and ultimately can fit them for a compression garment if that's what we all decide on.
So that kind of leads up to our next question. Do the amount of lymph nodes removed play a role in whether a patient has a higher risk of developing lymphedema or not?
They do. So many years ago, almost all breast cancer patients would have all of their lymph nodes removed, and as time has gone on, the studies have showed that that's not always necessary. So the breast surgeons have moved to just removing the sentinel node or few sentinel nodes, and we found that those patients have a lower risk of developing lymphedema in their lifetime, probably about 1 to 25%, whereas if you have a full dissection where they take out all we call them level 1 and 2 nodes, but a fair number of nodes in the axilla or armpit, then they probably have almost a 25% risk. So yeah, fewer lymph nodes is a lower risk. So that's why we rely on breast surgical colleagues to remove as few as possible.
For me, myself, I've had 8 removed, and it's one of those things that worries you as a breast cancer patient survivor. Like, I'm 6 years out, so as each year goes by, I get less scared that my cancer will come back, because statistically, being a triple negative patient, after 5 years, it drops significantly. But that lymphedema risk always gets you going when you have like a random arm pain. You're just like, I'm like, wait, which is this one? Are they the same size? Is one bigger than the other?
Right. Well, we don't want you to be paranoid, but it is good to be cognizant of what's going on with your body. And if you do notice it, lymphedema is easier to manage if you start dealing with it earlier. So if you wait until your arms are really swollen, or if you've had a few infections before you address it, it's a lot harder to get you back to where you need to be. And many times the treatment is just the massage and compression. It can be really effective, particularly if you get it started early. And other times we talk about surgical options.
And I will say that it gives me a lot of comfort having you as my breast reconstruction surgeon, that you also can treat lymphedema. So if that ever happens, I feel like I don't need to find who to go to.
Let's hope it doesn't, but yeah, those two things are complementary because it's the same patients.
If someone does not have lymphedema but have had lymph nodes removed, would they still need to wear compression garments during airline flights and or working out?
Generally not. However, if it makes them feel more comfortable, there's absolutely no harm. So it's totally up to the patient.
So you don't really need to.
We don't generally recommend that
Okay.
you wear compression unless you have lymphedema, because remember, most patients who have had lymph nodes removed do not have lymphedema, and wearing a sleeve can be cumbersome, particularly in the summer around the Jersey Shore. But if it gives you a sense of security, there's also no harm in
Like I can't do my gym tan laundry with my compression.
Right, or you
sleeve
have
on, yeah.
one arm that's not tan and one arm that is tan.
If a patient presents symptoms of lymphedema, what should they do and who should they see for management?
So usually if we already have a relationship, they'll come to me. Other times they may present to their breast surgeon or their primary care doctor. But ultimately, I'd like to see them. And what I'll usually do is we'll begin with all the measurements, we'll take a history. I'll refer just about everyone to a therapist, because they will also do complementary measurements, and they'll fit them for a garment, talk to them about the massage process. And then we can also evaluate them depending on the situation for some of the surgical options. Not everyone's a candidate for surgery, but there are a fair number of people who would benefit from it.
Let's talk about lymphedema surgery. What surgeries do you perform for lymphedema?
So generally there are two categories. One is we call the physiologic category, but those procedures are designed to improve the fluid drainage from the limb. And then there's the symptomatic category, and I'll explain each of those. But in the physiologic category, there are two. One is a lymph node transfer. So we take some lymph nodes, a bundle of fat with some lymph nodes in it, and we take it from a place where you're not going to miss it. And there's a test we do to make sure that we're not going to give you lymphedema by taking those lymph nodes out. And then we replace the lymph nodes in the area they were removed from, most commonly the underarm area. And we've found pretty good results with those, because think about it, you're going into an area that's been operated on, it's been radiated, it's scarred, and you're replacing that unhealthy tissue with brand new lymph nodes and other soft tissue that can avoid the scar contracture in the area, release any tightness the patient may have, and additionally provide the ability for the body to evacuate the fluid from that arm. The other procedure in that category is called a lymphovenous bypass, where we inject some special dye into the hand and we watch the dye work its way up the arm. And if it's an early enough stage where there's still functional lymphatics that you may see cut off after a certain period of time, you can try to connect those lymphatics to a vein right next to it and provide an alternate pathway out. Not everyone's a candidate for that, because sometimes the lymphedema has become so far advanced that you can't visualize any lymphatics, and if that's the situation, then that patient can't have a bypass.
How successful are these surgeries?
There are various studies, and all of the studies aren't done in the same way, so you can't really always compare apples to apples. However, we find that in the breast cancer population, people have had radiation or lymph node removal. 75% of people will have some measurable improvement, and about 90% of people will have the feeling of improvement, even if there's nothing you can measure, because their underarms are less tight, they feel better, the arm doesn't feel as heavy. So there's a subjective component to it as well. And if you're not a candidate for those two physiologic procedures for whatever reason, or if you've had them done and you've gotten your max benefit out of it, then the other option is there are two procedures, and most commonly in women with upper extremity lymphedema, we can liposuction the arm. So if one arm is significantly larger than the other, it weighs a lot, or volume is more, you can liposuction it. And the caveat is you need to wear a lifelong compression, or else it kind of fills up again. But we've had a fair number of patients who have one very heavy arm and one normal arm, and after the liposuction, they feel a whole lot better. With the liposuction, we have to get them right back into therapy, and they redo that whole process, and at the end of that process, we get them in a custom fitted garment. And then it's important to wear it all the time, whether you're flying or not, to maintain that improvement. And then the last category is pretty rare for a lymphedema, an arm or upper extremity lymphedema patient, but more people have this with their legs, where they develop like an actual mass that is getting in the way of their walking or functioning, and in certain cases we'll actually excise that, and it could change someone's life, but we don't see that a lot in people with breast cancer.
Okay. When should a patient considering having surgery for lymphedema?
Well, a lot of the studies show the earlier you intervene, the better the result. So it's good if we can address all of these issues before the arm swells up. Then you never need liposuction, because you never have to reverse all of the swelling. So if someone develops a mild swelling, we could pick it up early enough, we could do the lymphatic imaging, and they will most likely be a candidate for a bypass. And if they've had the axillary surgery and radiation, they're also a good candidate for the lymph node transfer. So those patients tend to do the best.
Does lymphedema come and go, or is it chronic?
It's chronic in that once you've developed it, it generally doesn't go away, and your progress your course depends on how well you manage it. Not everyone would progress at the same rate or to the same degree, but if you neglect it or don't compress it and wear the proper garments, you're certainly more likely to progress to a point where it becomes irreversible fibrosis and it's a lot harder to deal with.
Does your choice of breast reconstruction impact your lymphedema risk versus like implants over like a deep flap, something like that?
Generally not. When we do deep flaps, we often end up releasing the tissue in the same area where we transfer the lymph nodes. So you can actually combine those two procedures in someone who has lymphedema, but we don't generally think that your choice of an autologous, meaning your own tissue, or an implant reconstruction will affect the likelihood of you developing lymphedema.
I hear a lot about cording, and is cording related to lymphedema at all? And if someone does have cording, should they be concerned with developing lymphedema?
I think they're independent variables. We do see a lot of patients who have lymphedema who also have cording, because cording develops when the armpit or axilla gets really tight, and then you don't move your arm and you get a thick fibrous cord. So we usually try and treat that with physical therapy. And if we're unsuccessful, sometimes we will do what we call a free tissue transfer, which is the same method of reconstruction that a lymph node transfer is. It's microsurgery. You move tissue from one part of the body to another, so you can resurface the underarm area in the same way that you would transfer lymph nodes. And sometimes we're treating both at the same time. So cording doesn't independently increase your risk for lymphedema, but like I said, we see it often together.
There is a lot of talk about lymphatic massage. Who should seek out a lymphedema massage therapist, and what are the timelines of receiving this therapy?
So when I say therapist, I usually am referring to a certified lymphedema therapist. They're occupational therapists with additional special training. So basically anyone with a diagnosis of lymphedema should go see an occupational therapist. They're integral in the treatment, whether or not they choose to have surgery. Not every breast cancer patient needs to see one. However, we often send patients for physical therapy after breast cancer because the surgery has caused them to lose mobility in their shoulder, so that can help. And if they want to see a lymphedema therapist just for a prophylactic visit, I have no objection to it. Again, as long as it doesn't hurt you, go for it. So they can be very informative. They can tell you what to look for. So I think it's a positive thing all around.
I remember having my double mastectomy, and I had under the muscle, nipple sparing, skin sparing, and I actually ended up developing a hard adhesion on my left side. And you sent me for lymphatic massage, and it like broke it up. So that like it was like not lymphedema risk, but it was, I don't know, I guess it was like, does that happen often, or?
The physical therapists and the occupational therapists have a lot more in their toolbox than just lymphedema.
Yeah.
So it can be really helpful for patients to go through that if they're having these issues. So any therapy helps. It's always good.
And it feels good.
Yeah.
Who doesn't want a massage?
Absolutely.